Welcome to NP Certification Q&A, presented by Fitzgerald Health Education Associates. This podcast is for NP students studying to pass their NP certification exam. Getting to the correct test answers means breaking down the exam questions themselves. Leading NP expert Dr. Margaret Fitzgerald shares her knowledge and experience to help you dissect the anatomy of a test question, so you can better understand how to arrive at the correct test answer. So if you're ready, let's jump right in.
A 77-year-old man is in for a routine follow-up visit, has a 20-year history of type 2 diabetes and hypertension, as well as a 5-year history of stage 3B chronic kidney disease, or CKD. At this visit, his A1C is 8.4%, and his estimated GFR is 42 ml per minute. His BP is 128/76. He states he's feeling well and denies headache, visual changes, dizziness, and hypoglycemic episodes. His medications include metformin, amlodipine, lisinopril, and rosuvastatin. So just to recap, metformin, a biguanide, though nobody ever thinks of it that way, amlodipine, a calcium channel blocker, it's for his high blood pressure, lisinopril, an ACE inhibitor, and rosuvastatin, which is brand name Crestor, for his dyslipidemia. In reviewing his current medication, the NP considers which of the following options: A, prescribe glipizide; B, add pioglitazone; C, continue on his current medication without adjustment; D, initiate therapy with Canagliflozin. And the correct answer here is D, initiate therapy with Canagliflozin. So where should we start with a question like this? First, let's determine what kind of a question it is. Given the patient has been seen in the past, diagnosed and treated, and is now having ongoing care of how he's doing, this is an evaluation question where we're being asked to take a look at response to care. First, some background information. Type 2 diabetes is by far the most common endocrinopathy noted in North America, accounting for more than 95% of all people who have been diagnosed with diabetes. Type 2 diabetes is a disease of insulin resistance with relative insulinopenia. Insulin resistance itself causes an elevation in the blood pressure as well as dyslipidemia. Now, it's tempting with type 2 diabetes to focus solely on the blood sugar. It's also important to remember this is a chronic disease with multi-system consequences, and that the target organ dysfunction, sometimes abbreviated TOD, or the target organ damage for diabetes include the brain, the heart, the kidneys, and the vascular system. The effects on the kidneys is mentioned in this case, where the patient has a 20-year history of type 2 diabetes and now has a 5-year history of CKD. So adding the hypertension, diabetes, and dyslipidemia all together, this is no doubt what has caused the damage to his kidneys. The goals of treating type 2 diabetes, particularly in an older adult with comorbidity such as CKD, is to meet treatment goals via best evidence, as well as avoid hypoglycemia and further diabetic TOD. Here we're being given the scenario of an older adult who feels well, has no overt findings consistent with accelerated hypertension or diabetic TOD, but obviously concerning CKD. And if you're saying, well, I want some more information about his physical exam, et cetera, if that was important to the case, we would have been given this information. What do we notice is that his A1C is above goal. And in a scenario like this, you need to alter or intensify his pharmacologic therapy. I appreciate, one more time, we don't know a lot about him from a lifestyle viewpoint, et cetera, and that might be a good place to start. But given we're not provided with this information, we have to simply answer the question with the information we have. In other words, get rid of the yeah, buts from your vocabulary when you're in the middle of boards, where you're saying, Yeah, but I want to know about this. Yeah, but I want to know about that. Trust that you're being given enough information to answer the question. End of discussion. So, what do we know about treating older adults with type 2 diabetes? Whereas at any age in a person with diabetes, helping the person to achieve EBP treatment goals is important. Hypoglycemia avoidance is critical. It goes without saying that it's a dangerous situation for any person, but in particular to the older adult. In other words, one of the backbone principles of treating older adults with type 2 diabetes is to avoid hypoglycemia. What is the clinical presentation of hypoglycemia? Well, let's take a look at how a 25-year-old would respond to a hypoglycemic episode. The 25-year-old will feel tachycardic, sweating, develop tremor, maybe feel really hungry. That drives the 25-year-old who probably has type 1 diabetes to check blood sugar and go, oh, look, blood sugar's down to 45. Why is it so low? Well, I missed a snack. So then the 25-year-old acts to correct the hypoglycemia and everything is fine. How does the older adult respond to hypoglycemia? What they'll often do is feel weak, lightheaded, and have a marked increased risk for falls and select cardiovascular and cerebral vascular events. In other words, in the older adult, they'll fall, have a heart attack, and or stroke when they're hypoglycemic, where the 25-year-old got hungry, tremulous, and felt odd and was able to act. And by the way, in the older adult, that's called hypoglycemic unawareness, is that they just are not aware that their blood sugar is low and they just feel weak. As a result, choosing medications for the treatment of type 2 diabetes in an older adult, one of the main goals is to add on therapies that help avoid hypoglycemia, and that there are certain medications for the treatment of type 2 diabetes that are actually well known to induce hypoglycemia. And one more time, if we can get a 2-for-1 out of a medication, in other words, a medication that improves glycemic control while providing a degree of enhancement of minimizing the progression of hypertensive target organ damage, such as CKD, so much the better. I also want to remind you during the NP boards, if a more expensive branded medication is mentioned as a clinical option, but there's no comment about the medication being unavailable due to the person being uninsured or having a high copay, consider that the person can actually access this medication. With this information in mind, let's take another look at the question and the answers that have been provided. A 77-year-old man is in for a routine follow-up visit, has a 20-year history of type 2 diabetes and hypertension, as well as a 5-year history of stage B CKD. At this visit, his A1C is 8.4%, his estimated GFR is 42, and his BP is 128/76. He states he's feeling well and denies headache, visual changes, dizziness, or hypoglycemic episodes. His medications include metformin, amlodipine, lisinopril, and rosuvastatin. And reviewing his current medications, the NP considers which of the following options. A, prescribed glipizide. Well, we note that this man's A1C is above 8%. Recall that an A1C for a person in this age group is under 8%. And you could even make the argument that he'd be okay if his A1C was less than 7%, as long as hypoglycemia is avoided. In any event, his A1C is above age and comorbidity related goal. That's the really important part here. We do need to intensify his glycemic control, but glipizide is a particularly poor option. This is a medication class. It is one of the sulfonylureas that causes insulin release without regard to current blood sugar. Of the non-insulin meds used to treat type 2 diabetes, the sulfonylureas are associated with the greatest risk for hypoglycemia, particularly in older adults, and particularly in people with CKD, because the medication hangs around for a longer period of time because the damaged kidneys can't offload it. Another point when prescribing, or I should say, not prescribing a sulfonylurea, is in people who have an irregular meal schedule. They're much more prone to developing hypoglycemia on a sulfonylurea. And simply put, this is how the sulfonylureas work. They, in essence, tell the pancreas to release more insulin, but they do it in what I call dumb insulin release. In other words, not smart insulin release. So what they're saying, what the med is saying to the pancreatic beta cells is, hey, blood sugar is only 80, but keep releasing that insulin. Oh, blood sugar is 280. Hey, release the same amount of insulin. So in other words, it doesn't adjust the insulin released based on blood sugar. I'd avoid this medication, though it would likely get him to A1C goal due to the hypoglycemia risk and the increased risk and resulting cerebrovascular or cardiovascular events, as well as falls. I will say the sulfonylureas are cheap. That's one thing in their benefit, but they also have a lot of downsides. Would it be B, adding pioglitazone? Well, not really contraindicated. Pioglitazone that controls glucose by reducing insulin resistance via a mechanism that's different from metformin is not an optimal choice. In other words, to the best of our knowledge, we're not going to get like that 2-for-1 out of this medication. The other thing, pioglitazone use is associated with an increase in circulating volume, and many older adults will just not tolerate that. In other words, the 35-year-old will, the 70-whatever-year-old will not. And so let's take a look for a medication that's known to be associated with improved outcomes in an individual with CKD. I will tell you, though, pioglitazone would not induce hypoglycemia because it does not act on insulin release. Would it be C, continue on current medications without adjustment? As was mentioned, he does need help with glucose control. As a result, this is not the correct answer. Sometimes the test taker is tempted to choose an option based on the fact that the patient feels well. But keep in mind, hypertension and diabetes control can be quite poor, but the patient does not have significant signs or symptoms. And I've had patients come in and say to me, oh, yeah, my A1C is 12, but that's good for me and I feel fine. And I know it's not good. And they might feel fine, but that's kind of ignoring the issue at hand. And I will always say to a patient like that, I want you to be around in an optimal health for a very long period of time. So an A1C of 12 is clearly unacceptable. Would it be option D, initiate therapy with Canagliflozin? This is, of course, the best answer. And according to the ADA, a drug like Canagliflozin, which is an SGLT2 inhibitor, is considered a priority medication for a person with type 2 diabetes and CKD. The use of select members of this drug class can help prevent the progression of CKD while promoting improved glycemic control. And this is a medication class that works by causing an offload of glucose through the kidneys, has nothing to do with insulin release, so therefore there is not a hypoglycemic risk associated with its use. Key takeaway, knowing which medications for the treatment of type 2 diabetes and an older adult with comorbidity are considered to be priority medications and which medication should be avoided is important to safe clinical practice, optimal patient outcomes, and NP board success.
Thank you for listening to NP Certification Q&A, presented by Fitzgerald Health Education Associates. Please rate, review, and subscribe to this podcast. And for more NP resources, visit fhea.com.